All right, it is 9 o'clock and we will go ahead and get started. Good morning, everyone. My name is Beth Munson. Welcome to the Telemedicine Echo. I work for Missouri Telehealth Network and Show Me Echo at the University of Missouri in Columbia. I am now going to turn this over to our facilitator, Molly Brown, and she's going to get us started. Good morning, Molly.
Good morning, everybody. Thank you, Beth. Also, I would like to take a moment for our hub team to quickly introduce themselves. As Beth said, I am Molly Brown. I'm the program director for the Heartland Telehealth Resource Center in Wichita, Kansas. Now,
I'll go next. Hi, I'm Robert Stiles. I work with outreach and policy for the Heartland Telehealth Resource Center.
And I'm Karen Edison. I'm the Senior Medical Director for the Missouri Telehealth Network and our Show Me Echo program.
Good morning. I'm Tim Davis, Telehealth Manager at OSU Center for Health Sciences in Tulsa and the HTRC representative for Oklahoma.
okay, thank you very much. And now, if we're ready to go, we'll get started. I would like to introduce our presenter for today. Her name is Richelle Marting, and she's a partner with the Heartland Telehealth Resource Center. We're glad that you're joining us for the Telemedicine Echo series created by the HTRC and the Missouri Telehealth Network. Today, we will be discussing telehealth billing and coding with a case study focusing on a federally qualified health center that Richelle and I were able to work with based out of Missouri. As we begin today, there's just a few housekeeping items to consider. This session is being recorded and we'll share it with you afterwards. Your microphones have been muted. Please unmute or use the chat to talk. We will be monitoring that throughout the presentation. You can test out the chat by typing your name and organization so we know who's here. We appreciate you keeping your camera on so it feels like we're talking to people instead of blank screens or names. You'll be sent surveys after each session to complete with your team. We appreciate you filling them out to help us know what to address. As I said, our presenter today is Richelle Marting. She is a local attorney who is also a registered health information administrator and certified medical coder. Her practice focuses on medical coding, billing, and reimbursements, HIPAA privacy and security, health information management, and regulatory compliance. Richelle has been a great resource for our telehealth networks during the public health emergency, guideline updates, and flexibility extensions. Please join me in welcoming Richelle, and let's get started.
Thank you, Molly. Just checking everybody can see the slides. All right, good. Audio's working, camera's working, and slides are working. So check, check, check. Well, thank you for having me for the Echo this morning. I think this is a really good opportunity to take a real example of some questions that a local FQHC with real patients and real use of telehealth and some of the questions that they had and how they worked through those. And as they worked through those questions about the delivery of telehealth in their FQHC, how it really ties to some of the coding and billing requirements and nuances. And I think it just illustrates through the whole process of this idea of a way to deliver care, and then all of the detailed kind of back-end requirements on how you get paid for those services. So in doing this and in talking about the FQHC that we worked with locally in Missouri with a few of their telehealth questions, I'm going to illustrate how some of the pre-COVID, I don't know how else to mark it other than pre-COVID and intra-COVID and post-COVID rules, particularly with different provider types like FQHCs, RHCs, critical access hospitals, have been changing during these three kind of different time periods, what we can expect maybe after the PHE. And it really just shows how this is a constantly evolving process. Rules are changing, and how you can take some of these billing questions and concepts and continue to follow how the rules are changing during different periods of time. Hopefully, knock on wood, as we wind down the public health emergency and maybe work ourselves into the post COVID PHE era and what the rules are going to look like at that time. So a little bit about this local FQHC, how they came to us and the questions that they had. So this particular FQHC was using telehealth at the time they came to us. So sometimes I've got providers that say, hey, we want to do this. We want to remotely monitor patients, or we want to provide telehealth. We don't know where to start. We don't know how to do a pro forma on what we might get paid, how we might get paid, what codes to bill, and so on. So they were already doing it. This particular FQHC was really using telehealth in the mental and behavioral health context in particular. So they had a narrow focus on the way they're using it. And in doing that, there's been expanded coverage, expanded opportunities to provide telehealth, not only for the FQHC provider type, but in this narrower area of mental and telebehavioral health services. So the great thing was the area that they were trying to use it has some increased flexibilities during this intra-COVID PHE time period that had not been available previously. So in work, that was part of the questions that they came with, or what are the rules, what are the parameters with some of these flexibilities, and what restrictions are still here that we need to be mindful of, with some targeted questions on some pretty complicated rules specific to mental and behavioral health, telehealth, and FQHC telehealth billing that really illustrate how quickly coding and billing for telehealth services can get very complicated. And actually, we've got a session tomorrow, and Molly, you may want to talk about this at the end, focusing on this exact topic and the ins and outs of mental telehealth billing. That's going to do a much deeper dive into the coding and billing rules on that topic. So the three things that I think this really illustrates when they came to us with these questions saying, we're doing telehealth, we're doing it for mental behavioral telehealth services. There are some questions, there's some things we're seeing on coding and billing guidelines that we want to make sure we're getting correct. Especially because if you were to go out and search, you're going to see things that were in effect before the PHE that don't necessarily reflect today's rules and requirements, and that also may not reflect what's going to be in place after the PHE. So that was kind of the focus of some of their questions, is these different timeframes, what are the guidelines? So it shows how during the PHE, those flexibilities really expanded access and made this possible, made these mental behavioral telehealth services possible for the FQHC that may not have been possible prior to the public health emergency coming into effect. And I'll talk about why this is the case, but I also think it highlights the importance of leveraging professional societies, networks for policy and advocacy, because some things happened even just in the last couple of months with telehealth and FQHCs that were the result of national efforts to advocate on the access of telehealth for FQHC services for a longer period of time. And it talks about, we'll talk about following the changes in coding and billing, and why you can't just take the rules that are in effect today and run with that. Now more than ever, where we know we have where coding and billing changes are in flux, it's always a good idea to stay on top of those and monitor them, because I really think in the area of telehealth, we're going to continue to see a lot of changes as the PHE winds down after the PHE phase. But then I think we're going to continue to see legislation and changes in policy and coverage for telehealth over time that's going to naturally affect how we code and bill for these services. So let me start with this first piece on how this particular FQHC's model and the questions that they brought really show how changes to telehealth and the availability of telehealth and the rules surrounding when you can bill and be paid for telehealth have changed in a way that was favorable to the services that they were providing. So some specific questions that they came to us with. What are the rules surrounding telehealth for FQHCs now? And what is it going to look like when the PHE ends? They were already providing these telehealth services, but for FQHCs or other providers thinking about beginning a new area of telehealth service, that's a huge question that a lot of people have right now is, what is this going to look like if the PHE ends in July or in October or in just a few months? We want to deliver services that will be sustainable. And so that also means in terms of coding and billing rules, we want this to be sustainable. So what options do we have now? What will still be here? Do we know what's still going to be here when the public health emergency ends? And in doing that, we have to look at a lot of different areas. We look at Medicare as one source of telehealth rules because they have kind of set the stage for what some commercial payers are doing, and even the Medicaid agencies are doing. We have to look at licensing laws in each state. We have to look at commercial payer policies. We look at Medicaid policies. There are so many different places that we have to look at to answer this seemingly simple question: what are the rules surrounding telehealth services for FQHCs once the PHE ends? What are these in-person visit requirements? And as I mentioned, we're going to have a whole hour deep dive session into this one little tiny concept on telemedicine coding tomorrow. But because they are providing mental and behavioral telehealth services, they've seen and they've heard of this requirement that there's got to be an in-person visit before telehealth services are rendered for mental and behavioral telehealth. There have to be in-person visits at certain frequencies afterwards. What is that requirement? Does it apply to us? When does it apply to us? And when does it not apply? And so that particular question we really did a deep dive into to help them understand some of the facts and some of the misconceptions about when and if they need to have an in-person visit before beginning mental behavioral telehealth services for their FQHC patients. So I think to answer that question, to kind of illustrate how we walked through this example of what their rules are now and what it's going to look like after the public health emergency ends, with a focus on mental and behavioral telehealth, we have to kind of go through these different stages of the public health emergency and look at what the rules were before, what they are now, and then what we know so far about what the rules are going to be afterwards. So, and I know this may be a little bit remedial for some of you, if not, maybe just a good refresher, but before the public health emergency happened in March of 2020, the rules for the coverage of telehealth under the Medicare program are a combination of rules that are in the Social Security Act and regulations or interpretations from the Department of Health and Human Services. So the ones that are in the Social Security Act, Medicare as an agency can't change those policies absent the public health emergency, where the agency has greater rulemaking flexibility than it normally does. So some of these basic policies from the Social Security Act did end up having some flexibilities during the PHE, but absent a literal act of Congress, when the public health emergency goes away, those old kind of default restrictive rules under the Medicare program would come back into effect. So under these normal pre-COVID telehealth rules, we had rules surrounding the originating site. That's where the patient is located. And they were twofold. The first was that the geographic area where the patient is located had to be, I always say a rural geographic area because it's sort of an oversimplified way to say it. There's a very technical definition on what constitutes a rural geographic area where the patient has to be located during a telehealth service under the Medicare program in order for that to be a covered telehealth service before the PHE began. And the patient had to be at an eligible originating site location, like a clinic, like an FQHC, like an RHC, a critical access hospital. And with very, very limited exception, the patient's home was not an eligible originating site. So the patient truly had to come into the clinic, had to come into a healthcare location And that healthcare site had to be in a rural geographic area before a telehealth service could be covered. And that's only one of the requirements under the Social Security Act. At that time, FQHCs, and when I say at that time, before the COVID public health emergency, FQHCs were eligible originating sites where the patient could come in and have a telehealth service, typically with a distant site provider who might be a specialist. But FQHCs were not eligible distant site providers. So while the patient could come into the FQHC and sit there and have a telehealth service from another provider in another location, before the public health emergency, FQHCs were not eligible to reach out to the patient as the distant site provider to render a telehealth service to the patient. And that was a major restriction. It was also a flexibility that was created for FQHCs during the public health emergency that greatly increased the access and the availability to telehealth services with and from FQHCs that we still haven't, we still currently have those flexibilities today during the federal public health emergency. The other requirement, or a couple of other requirements under the Social Security Act that's set by Congress, is that telehealth services have to be rendered through interactive communication technology. Now, the Social Security Act and Congress did not define what it means to have an interactive communication technology. That piece, unlike originating sites, rural geographic areas, the definition of distant site providers that's set by Congress in the Social Security Act, the Department of Health and Human Services and Medicare can interpret and create rules on what it means to have an interactive communication technology. And prior to the public health emergency, with very, very limited exception, Medicare defined that as a live audio and visual two-way communication. So a synchronous audio-visual communication like we have now, where you all could jump on the audio and talk with me and see me. Typically, under normal rules before the public health emergency, that did not include an audio-only communication, which I think is interesting. It almost seems inconsistent with the idea that they have to be in a rural geographic area, because in rural geographic areas, as you all know, the internet access and the bandwidth to do an audio visual communication creates a challenge, and it may be difficult to connect with patients in that way. But I also think that's why Medicare required that the patient come into a healthcare provider site, with the idea that businesses may have access to better internet bandwidth, broadband access, to be able to facilitate an audio and visual telehealth communication. Then we can't just do any service through telemedicine before the public health emergency. Every year in about October, November, when the Medicare physician fee schedule final rule for the following year is published, there's a list, there's a spreadsheet of eligible services that can be rendered via telehealth. And they're identified by CPT code, by billing code, what can be delivered by telehealth. So it had to meet all of these requirements before the public health emergency to be a covered telehealth service. And for FQHCs, and for this FQHC, in particular, one of the biggest restrictions is that FQHCs were not eligible distant site providers for telehealth. So it really restricted the ways they were able to deliver telehealth. And from a coding and billing perspective, it was very limited, because all they could bill was an originating site fee. One code, one option, that was it. That's all that they could collect for telehealth under the Medicare program. So we all know what happened March of 2020. We had the Secretary of the Department of Health and Human Services at a federal level declare a public health emergency existed. And I think that actually was retroactive back to maybe a date in January of 2020. But what that did was create the power of the Medicare agency to enact rules and flexibilities without that change some of the basic parameters of telehealth services that exist under the Social Security Act without requiring that Congress make those changes. The limitation then is that when the public health emergency goes away, so does the agency's power to create those flexibilities that may not be consistent with what's in the Social Security Act. So these are temporary rules and flexibilities unless and until Congress enacts changes to the Social Security Act that would permanently make changes to the way telehealth can be delivered and can be billed. For FQHCs, during the public health emergency, a big change, a big flexibility for them is that they were now allowed to bill and render telehealth as the distant site provider from anywhere within the US, but also to patients located anywhere in the US, meaning we're not limited to rural geographic areas anymore. It allowed some services to be rendered as audio only and made the patient's home an eligible originating site. So I think for FQHCs, RHCs, critical access hospitals during the public health emergency, that first piece that they were eligible to bill as distant site providers, coupled with the ability to render a telehealth service to a patient at home, really opened up the doors to the types of telehealth services and the way telehealth could be rendered for providers that were not typically able to bill as distant site providers. These rules are still in effect because we're still, as of today, under the federal COVID public health emergency, even though many of the states, Missouri, Kansas, Oklahoma, and many other states, their state emergency declarations have expired, but the federal one is still there. So FQHCs, RHCs, critical access hospitals, speech therapists, PTs, OTs, professionals that ordinarily can't bill as distant site providers can still do that with these flexibilities. In conjunction with the list of telehealth services, the list of services that can be rendered via telehealth expanded significantly by multiples during the public health emergency. And that's one of the complexities as the public health emergency, as we look towards it potentially winding down, we're going to have a lot of different dates on when and how some of these policies revert. So then, oh, sorry, I went back instead of forwards. So then we kind of look to what we know about the public health emergency ending for this FQHC and what rules are going to stay in effect and for how long, what's going to go away as they're talking about their mental behavioral telehealth services. How do we code? How do we bill? How will we code and bill when the public health emergency ends? So just in March of this year, the end of March, I want to say the 29th of March, Congress, so now we're talking about the Social Security Act and things that require a literal act of Congress to permanently change when the agency's flexibilities, their authority to have those flexibilities go away. Absent this law that was passed, the day that the public health emergency ended, FQHCs like the one that we were working with could no longer bill as distant site providers. The home would no longer be an eligible originating site. Many things would revert back to the pre-COVID rules and immediately and very quickly change the face of the way telehealth has been delivered for 2+ years now. And so this law in March gave providers a little bit of leeway and a little bit of assurance that whenever the public health emergency ends, some of the flexibilities, but not all of them, that are currently in effect will continue for 151 days after the day that the public health emergency expires. So in that act, one of the flexibilities is that FQHCs are guaranteed to continue to be eligible distant site providers for telehealth services for 151 days after the public health emergency ends. So that's great. We know we have some assurance that we're going to get around 60 days notice, supposedly, before the federal public health emergency ends. The secretary of HHS has said, we'll give everybody 60 days notice, but 60 days is not a lot of time to you may even have patient schedules booked out 60 days or more in advance. That's not a lot of time to revert back to pre-COVID telehealth rules. So that act says FQHCs, you'll continue when the PHE expires, you'll have a 5-month period that you can transition back to the pre-COVID rules. Or what we're hoping for is that one of a number of bills that have been introduced at a federal level to make some of these changes permanent would hopefully have time to work their way through Congress and get passed. Among those, hopefully, the ability for an FQHC like this one to permanently be eligible to bill as a distance site provider for telehealth services. Under this law that was passed in March, also for a period of 151 days after the PHE ends, we know that the originating site can be anywhere where the patient is located within the US to receive a telehealth service. Now, that is a billing rule under Medicare. We still have to be cognizant of what state law licensing requirements are, which typically require that the provider hold a license in the state where the patient is located at the time the telehealth service is rendered. But for Medicare billing and payment purposes, we've got that flexibility. That also means that the patient's home will continue to be an eligible originating site for 151 days. It also means the patient doesn't have to be in a rural geographic area. So we've got several months of assurance that we can continue to provide telehealth services in that way. Now, when we look at the list of eligible telehealth services, this is where it starts to get complicated because the effective dates of some of these services that can be rendered via telehealth service don't align with the end of the PHE, and they don't align with this March law that gives us 151 days after the PHE ends. The list of telehealth services has a combination of some services that will continue to be eligible to be rendered as telehealth through December 31st of 2023. Regardless of if the PHE ends this year or next year, and some telehealth services that can no longer be, let me say that a different way, some services that can no longer be rendered as telehealth the day that the PHE ends. Though that time frame, the list of eligible telehealth services is completely separate from the law that was passed in March and some of the rules under the Social Security Act that will only be in effect for 151 days unless there's another law passed to make them permanent. In general, when the PHE ends, a lot of the services, the telephone only, the audio only phone calls go away when the PHE ends. So that takes us to all of that background, then takes us to some other rules specific to the delivery of mental and telehealth services that go beyond what's in the Social Security Act and the provisions and the flexibilities during and after COVID. So there was several years ago, even before the COVID public health emergency came about, there was a law passed called the Support Act. And the Support Act was one of those narrow exceptions that created some enhanced access to telehealth, even before the public health emergency, to patients who were at home. It allows the patient's home to be an eligible originating site, even before the PHE and even before that was available for all telehealth services. Specifically in the context of a patient who had a substance use disorder or who is receiving care and treatment for a mental or behavioral health condition that coexists with a substance use disorder. And in those narrow instances of telehealth under the Medicare program for a patient with substance use disorder or mental behavioral health conditions co-occurring with substance use disorder, and the patient is at home, the Support Act created some enhanced coverage and would allow and would pay for those telehealth services. So this is that pre-COVID, pre-PHE period where home is only an eligible originating site for certain very narrow situations, and this was one of them. Then in the middle of the COVID PHE, when home became an eligible originating site for all telehealth services, the Consolidated Appropriations Act of 2021 passed, and it took what was available under the Support Act and expanded that coverage for mental and behavioral telehealth services to say, okay, what was in effect only covered telehealth to patients at home if there was substance use disorder and or mental conditions that co-occur with substance use disorder. This says we're going to expand that and allow the patient's home to be an eligible originating site for all mental behavioral conditions for telehealth. It doesn't have to co-occur with substance use disorder to be covered. Now, the tricky thing or the confusing part about that is during the PHE and the flexibilities that we had during the PHE, these Consolidated Appropriations Act changes, this expanded coverage for telehealth for mental behavioral conditions, it really didn't represent any change because of the PHE flexibilities that allow us to provide any telehealth service to a patient at home. But what it does, after the PHE ends, the day that the PHE ends, this says you can continue to provide telehealth services for mental and behavioral conditions to patients at home. Even when the PHE ends and we revert back to normal requirements where the home is not an eligible originating site, that can still be a covered telehealth service. What happened when the March law was passed, it says, is that the home as an eligible originating site, that's going to continue to be a flexibility for 5 months after the PHE ends. So with that, the enhanced flexibility for mental behavioral telehealth services to patients at home really doesn't kick into effect until 151 days after the PHE ends. At that point, unless other laws come in effect and change things, 151 days after the PHE ends, the home will no longer be an eligible originating site for all other telehealth services. It will continue, though, to be available as an eligible originating site for telehealth services provided to evaluate or diagnose or treat mental or behavioral conditions that do not necessarily co-occur with substance use disorder. Then, and only then, only 151 days after the public health emergency ends, do some of the requirements under the Consolidated Appropriations Act kick in. And this is where this sort of infamous in-person visit requirement comes into play. Only 151 days after the public health emergency ends. Only when we have to rely on the Consolidated Appropriations Act and the ability to provide telehealth to a patient at home do the in-person visit requirements kick in. When that's the case, under the Consolidated Appropriations Act, there has to be an in-person visit with that patient within 6 months of providing the first telehealth service to the patient at home for a mental or behavioral health condition. That's that's in the law, that's in the statute. So it's not something that Medicare as an agency can change after the public health emergency goes away. The other requirement, if we have to rely on the expanded coverage under Consolidated Appropriations Act, 151 days after the PHE ends, so the patient's at home. And in order for that to continue to be a covered telehealth service, we then have to have periodic in-person visits, generally every year for that patient, but there are exceptions to that. If the disadvantages or the risks outweigh the benefit of an in-person visit. So let's say you're in an area where in order to get that in-person visit by the distant site provider, the patient would have to travel 5 hours to have an in-person visit. And we risk the patient not continuing their mental behavioral treatment if they have to come in for that in-person visit. The provider can document that the hardship and the disadvantages outweigh the benefit of those periodic annual visits. And there can be some flexibility there. There's not flexibility on the initial in-person visit requirement, unfortunately, at this time. The other flexibility that only kicks in 151 days after the PHE ends, meaning because we have this flexibility already during the PHE, we don't need to rely on the Consolidated Appropriations Act yet. But once all those flexibilities go away, 151 days after the PHE ends, we can still provide mental behavioral telehealth services to a patient at home using audio-only communication technology. And that will permanently be an option if the patient doesn't have the ability to connect by visual communications or doesn't want to connect by visual communications. We can provide those services as an audio-only communication. So you can see how complicated this gets in terms of the timing of when these rules come into effect and when these rules go away and how that changes the coding and the billing requirements for these services. I'll add as a side note, just yesterday, I think, the Federal Office for Civil Rights came out with some guidance on how audio-only telehealth services are impacted by the HIPAA privacy and security rules. So we've had some HIPAA security flexibilities during the public health emergency. Now we have some guidance on how security rule requirements continue to apply after the public health emergency ends. So while it's not directly related to coding and billing, it is instructive on how we want to model these services as a sustainable service from a coding and billing perspective, but also from a privacy and security perspective, and what we know federal agencies are going to expect in terms of security on how we deliver those services. So you can see how the evolution of the Federal Department of Health and Human Services and their waivers and flexibilities during the PHE. And then we had this act of Congress in March that by the way, it made FQHCs and RHCs distant site providers for 151 days, but it very notably left out critical access hospitals from that law. And so I think it really emphasizes and highlights the importance of policy and advocacy for groups like an FQHC professional association, rural health associations, to go to their representatives and say, here's what we're doing during the PHE, here's what we need on a permanent basis, here's how it has improved access, decreased waiting times, improved the availability of specialty care to our patients. And I've got a link here, I won't go through it, that you can view the National Rural Health Association's 2022 policy agenda. And in there, expanding broadband access in rural areas, but also they have a focused effort on making permanent and expanding the access to telehealth services, taking these temporary waivers that have been extended for 151 days after the PHE, but they're really advocating for bills that have been introduced to make those changes permanent. And our hope is that by the time the PHE ends and by the time that 151-day timeframe expires, groups like this that are advocating for different telehealth policies, that are important to their constituents, are able to effectuate permanent change under the Social Security Act that we're going to be bound by once that 151-day period ends. So this kind of shows the timeline and the evolution. Again, why it's so important then to also keep track of what today's rules are when it comes to coding and billing for telehealth services. So we had pre-COVID, FQHCs could not bill telehealth services as a distant site provider. They were limited to just being the originating site, facilitating the telehealth service when the patient comes into the FQHC. They had one code that they could bill as the eligible originating site. The distant site provider handles all of the coding and billing in terms of the telehealth service that's actually rendered. Then we have, during the PHE, a temporary flexibility that allows FQHCs to bill as distant site providers. So now FQHCs have to be aware of the patient's location. We've got to be aware of reporting place of service requirements on our claim forms. We have to know a lot more about the services that are eligible to be rendered as telehealth services and CPT code selection, billing as distant site providers. We have to know when it's done as a telehealth service, do we bill the location where the patient is as the place of service, like home? Do we use place of service 02, which is a telehealth service? Do we use a brand new place of service code that was created this year, place of service 10, a telehealth service to a patient who is at home? And all of that depends on different payer and policy requirements. So they significantly added to their sort of repertoire of tools and rules on how to code and bill for telehealth services during the PHE if they were going to act as the distant site provider. We've had place of service changes. So we have rules that generally outside of the public health emergency, when we render a telehealth service, we use a place of service code 02. It doesn't matter if the patient is physically located in an FQHC, at home, in the parking lot of the grocery store. When we do a telehealth service, that's the place of service code we would use. During the PHE, Medicare changed their policy and said for telehealth services, use temporarily during the PHE, use a place of service code that describes the location where the patient would have received that service if it had been rendered in person. So that might be the FQHC place of service. It might be 11 for an office. It might be a hospital inpatient, hospital outpatient. That's a change during the PHE. And I anticipate that as the PHE ends, that rule is going to change again, and we'll have new instructions. So we've got to stay on top of that. We've had modifier changes. Whenever we report the CPT code for the telehealth service, we have guidance on, there's a modifier 95 that describes a telehealth service that used to be required. Then Medicare said use place of service 02 instead of 95, but we still have other payers wanting modifier 95. Then during the PHE, when the place of service reporting changed, we have to add modifier back on again. So it was there, then it wasn't, now it is. And it's just another example of things that are changing with coding and billing for telehealth services during this pre, intra, and post-COVID period. Then we have the law in March that extended the ability for FQHCs to serve as distant site providers for 151 days, meaning we have certain services that continue to be available as telehealth services for FQHCs to render as FQHCs on that telehealth list, and a lot of coding and billing requirements where the time frame for those changes will be extended for 5 months. Now, each individual service may also have its own coding and billing and coverage requirements that we have to be aware of. So for this FQHC that brought the question, as an eligible originating site, their rules were pretty narrow that they had to keep in mind. And it was really the distant site provider that's selecting among different CPT codes and modifiers and places of service that they had to be aware of what the coverage requirements are. But this FQHC, now acting as a distant site provider of telehealth services, has to be aware of whether, chronic care management or different services have frequency limitations. For example, a telehealth service to a patient located in a skilled nursing facility can only happen once every, I can't remember if it's 3 or 14 days. I know it changed fairly recently, but there are frequency limits, and there might be diagnosis code requirements and restrictions, like under the Support Act and Consolidated Appropriations Act, having a mental or behavioral health diagnosis on the claim. So it really adds, as you can see, to the complexity of that. And then, of course, it's hard to know exactly how policies are going to change after the public health emergency with respect to procedural coding, place of service, and modifier reporting, although I anticipate a lot of that's going to revert back to some pre-COVID rules. All right, so I'm going to pause there, and I'll let Molly or Beth add the date and your topic for your next ECHO session. But I also welcome any questions that you have. And hopefully this is just a good illustration of a very narrow service in the delivery of telehealth and how we have to consider the provider type, the different payer rules, the different timeframes in their relationship to the public health emergencies. And how important it is to stay on top of the coding rules and to advocate for your service type, your provider type, on keeping some of the telehealth policies that are very important for your delivery of services.
Richelle, we do have a clarifying question from one of our participants. Heidi, would you like to unmute yourself and present to Richelle, or would you like me to? See, I think there she is. I think she unmuted. There she is. Oh, we can't hear you. Sorry, Heidi. It's okay. I'll go ahead and read it. Heidi's clarifying question is, if my patient is at the counseling clinic with the counselor and I am at my general practice office, they are in different counties, would billing be the same as if they were at home?
So great question. I'll kind of walk through the different things we keep in mind. So I've got your question pulled up in the chat, so I always have to kind of visualize it. We have a patient who's located in another provider office, a counseling clinic, and then you are at your general practice office. So if you are delivering this telehealth service to the patient located in a counseling clinic, the counseling clinic is acting as the originating site. So they could potentially bill an originating site fee for kind of hosting or facilitating the telehealth service where the patient's located. So in that sense, it's different than if the patient is at home, because if the patient's at home, nobody gets to bill an originating site fee. No one is incurring the practice expense or the overhead of facilitating that telehealth visit. So that's one difference. For you as the distant site provider of that service, I guess when you say your general practice, so I'm not sure if that's FQHC, RHC, or just a general provider clinic, but as the distant site provider, then it's different in the sense that during the PHE, the place of service code that you report for the telehealth visit is not going to be a 02 or a 10. Those are two different telehealth place of service codes. It's probably going to be like an 11, an office clinic place of service, and then you may need a modifier 95. So that's a little bit different during the PHE. Otherwise, It is different than when the patient is at home, because after the public health emergency ends and after that 151-day grace period after the PHE ends, you could continue to provide telehealth services in this way as the distant site provider to a patient at an eligible originating site, assuming, I suppose, that counseling clinic qualifies as a rural geographic area. And if so, that same delivery model will continue to be available, whereas your same distant site telehealth service to a patient at home may not be available after the PHE ends unless certain requirements are met.
Heidi did clarify FQHC.
FQHC, okay. So after the 151-day period, after the PHE ends, unless another law is passed, as an FQHC, you would not be able to bill as a distant site telehealth provider. So that would change. And that's the same whether the patient was located at home or the patient is located in the clinic when you're rendering that telehealth service.
But Richelle, isn't it true that every one of the major, telehealth bills that are out there include that continuing having FQHCs and RHCs as originating as distant sites? So I mean,
Many do. Yes, it is absolutely a focus of the bills that are out there, as is eliminating this 6-month in-person visit requirement for whenever that applies. But absolutely, they do it in different ways. Some of the bills say FQHCs and RHCs will be added to the list of eligible distant site providers. Some of the bills do it in a little bit different way and say any provider who's eligible to bill under Medicare should be an eligible distant site provider as long as they're acting within their scope of practice. But one way or another, that is an extremely common theme among the federal bills that are out there for telehealth. Yes.
Dr. Varan, did you want to unmute yourself and with your question?
Sure, it's a little bit off topic, but in addition to telemedicine, we've expanded a remote monitoring program and are doing remote monitoring program. But at the same time, we turned on Apple Health's physician dashboard. Now, what this does is it gives us a robust patient-controlled view of what's in their health app. So if there's an iPhone app and they're tracking their steps, their weights, their blood pressures, or whatever, we get to see all of that information, including sleep. And this has been very, very useful because it's under the patient's control. And we have this nice dashboard that most of us that are iPhone users would love to have ourselves, but Apple hasn't released that yet. But on the physician side, it's there. The question comes up, well, this is even more robust data than what we're getting through our remote management program. Can we bill for remote management services every month?
It's a great question. And you're exactly right in the sense, I don't know that it's off topic, but if categorically, because it's not classified as a telehealth service under the Medicare benefits.
Yeah.
The great thing about the option for remote patient monitoring is we don't have originating site restrictions. We don't have the eligible distant site provider. All of those complications on the provision of telehealth don't apply to remote patient monitoring. So it is and it isn't off topic. I think it's a really great question because so many providers are doing remote patient monitoring. And I kind of call these quasi telehealth because it's still kind of a behind the scenes. It's not a face-to-face service. So I think it very much is appropriate and relevant. And for remote patient monitoring, one thing, Dr. Varan, I know we've got some recorded sessions on HTRC's website that do a deep dive into it, but a few going into that episode of care, we need an order from a provider. So there's got to be, we're managing congestive heart failure and that's why we're tracking weight, or we're managing high blood pressure. So you're having them take their blood pressure at home, managing obesity, so you're tracking steps, whatever those conditions are. You have an order that identifies what what you're going to track and kind of what the parameters are, the ideal blood pressure range for that patient or so on. So that's kind of the first step. The second is that the device that's being used has the ability to transmit that data automatically. So it's not input by the patient. So I use like a MyFitnessPal type app, where you track calories, I input that, or you step on a scale and I input weight. So that's not what the remote patient monitoring, it has to be a scale that transmits the measurement to the app. It has to be a blood pressure cuff that transmits the reading data to the app to qualify for remote patient monitoring. And then if that's all the case, we've got the ability to bill for the education and setup for the patient, how to use, the scale, the app, the blood pressure cuff appropriately to get accurate readings, how often you want them to take their measurements. So you get there's kind of a one-time initial setup code for that education and training. There's a one-time code that you can bill for the equipment essentially. And it doesn't matter if you're giving them a $5 thermometer or a $50 digital scale, the price is the same, unfortunately, for that one equipment setup code. But then for the monthly monitoring, we have to have at least one interactive communication with the patient in a month, which can be a phone call. Richelle, hey, I noticed you didn't step on the scale today, or your blood pressure was a little bit high. What's going on? Did you take your medicine? One outreach a month and a total of 20 minutes of monitoring the patient's data. So we have to track our time that we're spending looking at their measurements and monitoring against their plan of care. When we document all of those things, then you could potentially bill for remote patient monitoring. Now, if that's not the case, that the scale, the blood pressure cuff or things are digital and automatically transmitting that data, there are new code options called remote therapeutic monitoring. Very, very similar. They're structured the same way in terms of the setup, the education, the equipment, and then the monthly monitoring, but they're more designed for subjective input, like the patient putting in their caloric intake. If they're short of breath, if they feel like they've got swelling in their legs and they're subjectively inputting that data, those may be options too.
I think we have just a couple minutes for one more clarifying question from Ariel Harriman with their clinic. They also have remote monitoring as an FQHC, but they have not been able to find an avenue to bill. Any suggestions? And you may have already covered some of those options with your response to Dr. Baran, but if there's anything additional.
Yes, and I probably should have asked that of Dr. Baran as well, because that is unfortunately one ongoing limitation for FQHCs and RHCs, that right now Medicare considers remote patient monitoring to be part of the all-inclusive rate for an FQHC or RHC and not a separately billable service like it is for some I don't know what the term is, a regular clinic setting that can bill for the professional fees for remote patient monitoring. So that is one limitation, Ariel, that as an FQHC, it's limited in your options to bill for remote patient monitoring at this time. Although, kind of going back to that slide on advocacy and policy, I really would encourage you this summer around July, usually like July 5th or July 10th, the Medicare proposed physician fee schedule comes out. And when remote patient monitoring, when some new codes were coming out to pay for remote patient monitoring services, I want to say around 2019, that was brought up. Are these payable for FQHCs and RHCs? And at that time, Medicare said, no, we think it's part of the all-inclusive rate. However, that's an agency decision that CMS could change their mind on. And I think taking data and submitting it as comments to the Department of Health and Human Services with the proposed rule to show the extra cost, the extra, resources that go into that above and beyond what's typical for a per visit rate for an FQHC or RHC, and particularly emphasizing the benefits to patients. not only for your clinic, but you leveraging any rural health associations that your FQHC may be a part of can really make an impact on Medicare's decisions to open that up as a potentially separately billable service for FQHCs and RHCs, like they've done with other care management services over the last several years. So I think that really highlights that the importance of advocacy in what you're doing to try to be reimbursed for that.
Super quick, also, the National Association of Community Health Centers is a powerful organization in DC. So I would also advocate at the National Association because they've always been good on telehealth and they can carry that message in a powerful way.
Well, I think we are at time. So thank you, Richelle, for your presentation today and for the questions we had from our participants. For our final echo for this series is July 12th. So keep your eyes open for the emails. That topic will be evaluating your program with Dr. Evelyn Nelson and Dr. Mirna Besovic. So keep your eyes open for that information. And please feel free to reach out to the HTRC for any additional questions for Richelle that you may have following today's echo. I will put in really quickly the link if you are interested in joining the HTRC education series. You can use that link in the chat box to sign up for those updates as well. We do have one tomorrow that is specific to in-person visits in the 6-month rule, and it'll be at noon. So please check out the website if you have interest in learning more about that. At this time, I think we are finished, and I want to thank the Hub team for your contributions as well. And everybody have a great day and stay cool.
Bye, everyone. Thank you.